Are you able to see this?
Yes, sir.
Yes, sir.
Yeah, we are going to see the last time we left in the middle of the management of mandible actually. Okay, we're going to see how the management of the mandible has to be done in these oral cancers. This is all we imagine. All these are not very important for you. Just for the sake of understanding what is being done in our specialty, you can just listen like that. So no need to memorize all these things and just understand the concept. That's it. So that you can have a basic idea of what is being done for what as a tumor. Okay. So mandibular alveolus, as we have seen last time, the mandibular alveolus, the one which is present at the level of your mandible teeth sockets, that is the mandibular alveolus. It is the alveolus, and the floor of the mouth, as we know, and buccal mucosa and retromolar trigone. So all these regions, number 1, 2, 3, and 4, retromolar trigone, all these regions involve the bone of the mandible. Then what is to be done is important. There are significant consequences. Why? Because the management is based on the involvement of mandible only. There are many questions to be answered. How does squamous cell carcinoma affect the mandible? It can be invasive, number 1, or erosive. Invasive, as you know, it becomes like a fingers or islands of the tumors with no obvious osteoclastic activity. Osteoclast activity is not there for invasive front. Whereas in erosive front, it is a broad advancing front with osteoclast. Okay, so OC is erosive activity. OC is erosive and it has got broad advancing front with a connective tissue between the tumor and the bone. There is a big connective tissue between the tumor and the bone. There is a big connective tissue between the tumor and the bone. That is called as erosive way of involvement of the mandible. The depth of the invasion increases, there may be more invasive cancer. So if you take that this is the mandible and the depth is increasing, it is an invasive cancer. Okay. So invasion has got osteoclastic activity, no osteoclastic activity, erosion has got osteoclastic activity. Osteoclast is new bone formation or bone dissolution and new bone formation. There is osteoblast and osteoclast, something like that. A large and invading tumors, they have a invasive pattern and involve the mandible. So large and invading tumor, for example, large and invading tumor, they have got an invasive pattern. Osteoclasts are very less over here. Connective tissue is very less over here. Okay, but it goes like a fingers. Invasive is like a fingers. It goes like a finger. They enter the mandible at the contact and junction of the attached and reflected mucosa. The patient is edentless or dentate. Where do they enter actually? So when you take a socket like this, the mucosa is attached over here. At this point, they enter and they try to erode the things. The mandible is always at risk where the tumor is in contact. So wherever the tumor is in contact, it can be at risk, and it is taken into account while planning the resection. So that is taken into account while planning the resection. So clinical fixation is this already I told you last time is not necessary for bone invasion. Clinical fixation is not necessary for bone invasion. It is the size and extent which dictates the pattern of the spread in the bone. So the size of the tumor and extent of the tumor which dictates the pattern of the bone involvement. It's not the anatomical features or it is not the inferior alveolar nerve, it is not the periodontal ligament. I am telling inferior alveolar nerve because inferior alveolar nerve is involved, it becomes a 4B as you could know here. So T4B, it becomes T4B. This is not going to dictate the pattern of spread. It's not, this is going not, that is the size and extent is going to dictate the pattern of spread. It's not the inferior alveolar nerve or periodontal ligament. The spread in the mandible is by means of inferior alveolar nerve or medullary space is rare and justifying 1 centimeter margin. So 1 centimeter margin is okay for mandible also. What he is saying is the inferior alveolar nerve is helping in spreading. The inferior alveolar nerve is in the mandible like this. So it helps in spreading and it's not the medullary space. These are all very rarely involved. So there 1 centimeter margin is okay for the mandibular tumors. Tumors demonstrating an invasive pattern, that is finger-like pattern, spread more likely. They spread more likely. They give cervical metastasis more commonly, and they give extra capsular extension. When extracapsular extension is there, extracapsular spread is there, it is a dangerous tumor. It is an aggressive tumor. It is an aggressive tumor. You should understand that. How do we detect the bony invasion in mandible? You have to go for imaging. It is necessary. It's an appropriate type of resection. So based on imaging, you plan the type of resection, what to remove and what not to remove. There is no single investigation that can predictably say, as we have discussed already, orthopan tomogram. Orthopan tomogram, it tells the mandible, tells the coronoid process, it tells the condyloid process, and it tells the status of the teeth, and all these things in a single, as a pan tomogram. So like Pan India, as you could see Pan India movie, the pan tomogram is the mandible is completely given. It also tells us about the styloid process that is there over here. All these things are shown. What is OPG? When someone asks, you should say orthopan tomogram is a plain radiograph. Height, dental anatomy, dental pathology, all this can be seen in OPG. It should be remembered that plain radiographs do not detect the initial invasion until 30% demineralization has occurred. For plain radiographs to detect, minimum 30% demineralization has to occur. Minimum 30% demineralization has to occur to determine in a plain radiograph. So, clinical examination and orthopan tomogram, they are inadequate. They are not just enough. So, what should you do? Axial MRI with T1 stir fat suppression. They say this is the technique of MRI. T1 stir and short tau inversion recovery. STIR is short tau inversion recovery, fat suppression. They are very sensitive. This is good for the protection of the bone, and it is a primary site of involvement, and adequate specificity is also there. What is the other way you can do is bone scintigraphy. Bone scintigraphy is one more investigation, or single photon emission computerized tomography. It is called as SPECT. Single photon emission computerized tomography. Single photon emission computerized tomography. It's called as SPECT. Also helpful for bone involvement. What are the investigations you do for bone means you have to do this and when bone involvement is equivocal means it is doubtful whether it is involved or not. You have to do in surgery, you have to do periosteal stripping. You have to remove the periosteum and look for the cortical bone disruption, whether it is there or not, and plan the resection. And that situation, you plan the resection. How do we manage the bone involvement? When mandible is involved, how do we manage it? There is a rim resection or marginal mandibulectomy for T1 or T2 tumors and early invasion of 5 mm. Early invasion of 5 mm. With adequate bone height is removed, dependent on preoperative image. Based on preoperative imaging, you plan and clinical examination and periosteal stripping. So rim resection or marginal mandibulectomy. Rim or marginal means if this is a mandible, you have to remove a rim of it, or marginal mandibulectomy. Traditionally, rim resections are conducted horizontally. So as you could see, rim resections are conducted horizontally, they are removed. Tumor may enter the mandible at any point of contact and becomes apparent that socket should be angled. So when you are cutting the mandible, you should have an angled socket. Angled socket. Angled saw cutting is done for mandible. So marginal resections of the retromolar region may include the coronoid process also. So what is coronoid process? This is the condyle, this is the coronoid process, this is the mandible, this is the coronoid process. So when you are doing a retromolar trigone region, as you know, retromolar trigone is in front of the coronoid process. So this is the anterepillar and this is where distobuccal margin of the upper teeth and lower teeth. This is becoming the retromolar trigone region in front of the, just above the third molar and below the third maxillary molar. We have to preserve the inferior alveolar neurovascular bundle by doing a marginal resection. So because there is a avascular necrosis chance in that, there is a chance of avascular necrosis and iatrogenic fracture. You should be very careful. You should not produce iatrogenic fractures. The anterior and posterior margins should be curved so that to minimize risk of iatrogenic mandibular fracture. So curved margins should be taken. The anterior and posterior margins should be curved so that the fractures will not occur. So we have to go for rounding of the edges of the rim resection. It minimizes the risk of bone exposure post-operatively. Rounding of the edges of the rim resection is very important. It minimizes the risk of trauma and microvascular free flap if it is used for reconstruction. So when you cut, you should not cut it sharply. You should make it a round cut so that the fracture chances post-operatively will be decreased. The fracture chances post-operatively will be decreased. If the depth of the mandible following rim resection is less than 10 millimeters, you can go for a segmental resection. Okay. Consideration should be given. So this is what is rim resection. Rim resection is you're removing a rim. Segmental means you're removing a complete segment. That is segmental resection. So what is segmental mandibular resection? If you are removing a part of a mandible like this completely, you have to do a composite reconstruction. That means you should get a bone from somewhere and then replace this last part, and should be conducted for extensive mandibular invasion. For extensive mandibular invasion, you should be doing that. Are deeply invading soft tissue. So when you are deeply invading the tumor is there, you have to remove that. Even in previously irradiated mandibles, you will be doing segmental resection because rim resection will not work out. Previously irradiated mandibles, you go segmental resection. 1 centimeter margin is always there for a soft tissue tumor. Okay, 1 centimeter margin. This, remember this 1 centimeter minimum. If this is the tumor, you have to go for 1 centimeter margin. That is important for head and neck. So you have to go for frozen section analysis also. You have to go for frozen section analysis. So intraoperatively, you have to go for, so after post-op, you go for histopathology. Histopathology, that is called as biopsy. Histopathology is also called as biopsy. During surgery, intraoperatively, the pathologist comes inside, that is called as frozen section. That is called as frozen section. You should keep it in mind. So bone involvement and prognosis, how does it occur? So you have to, if a planned resection occurs following guidelines, as we have already said, long-term prognosis and recurrence rate does not differ. It's a good one that you can go for marginal resection, or number 2 is segmental resection. Anything can be done. But in presence of bone involvement, rather than the depth of bone invasion, if bone involvement is there, it is the main factor of long-term prognosis. Bone involvement is always a factor of long-term prognosis. Bone involvement is a factor of long-term prognosis, not the depth. The depth is not important. Bone involvement is important. It has been proposed that only tumors with invasive tumor front classified as T4. So there are 2 types of tumors, invasive and erosive. I told you invasive will have finger-like projections. Erosive will have connective tissue in and around. So it is an invasive tumors front as opposed to an erosive front classified as T4 tumors. So these invasive tumor fronts will have the chance of getting more into a T4 tumors. And local recurrence is usually a soft tissue margin status. Local recurrence is depending upon soft tissues. In and around soft tissues are basis for the local tissue recurrence. So they recur. Once again, even after removal of surgery, they recur. So the quality of life implications. So rim resection. So how it is going to affect the quality of life? It is an excellent functional and cosmetic outcome. When you take my mandible like this, so a part is removed, it is functionally good and cosmetically good. Rim resection, it maintains the structural integrity and preserves the sensation of the lower lip. Sensation of the lower lip is more important. Also, muscle attachments is also important. Why? Because muscle attachments and sensation of the lower lip, these are going to affect the functionality of the tumor. Functionality. If not, they cause something called as anti-gump deformity. Once you remove, for example, a mandible is there like this, you are removing this mandible, the mandible becomes smaller, maxilla is this much bigger. So it is called as anti-gump deformity. Anti-gump deformity. Next time I'll show all the pictures. This time I could not put all the pictures. Anti-gump deformity. What is anti-gump deformity? That is going to form like this. So quality of life is influenced by many factors. Site of bone, type of bone, soft tissue, type of reconstruction, and adjective leadership. These are all leading to quality of life issues. Quality of life of a cancer patient, quality of life post-op is going to be affected by site, type of bony resection, and along with the soft tissue resection, reconstruction, and radiotherapy. All these are very important as far as the quality of life is important. whether oncologically is sound or not, a rim resection should be the resection of choice. Rim is always better than segmental. Why? Because it is going to the rim is always better than, this is called as rim resection, and this is called as segmental resection. Completely segment is removed, segmental resection. So rim is always a better one. Rim is the choice. However, it has been demonstrated that there is little or no difference in the quality of life between a rim and a segmental resection. When you do a composite microvascular free tissue transfer, so composite is, it involves the bone plus cartilage, microvascular along with blood supply, and free tissue transfer along with tissues which are not connected to anywhere. If you do free tissue transfer, I said the best reconstruction is FTT, free tissue transfer. Best reconstruction is FTT. Minimum basic reconstruction is split skin graft. I told you in the beginning itself. So basic reconstruction is split skin graft, and best is free tissue transfer. Best is free tissue transfer. Particularly if resection is greater than 4 centimeters. First, you don't remember, this one is a reference. Okay. So resection is greater than 4 centimeters. So when you go for more than 4 centimeters removal of a tumor, you have to go for free tissue transfer. Free tissue transfer is the best method of reconstruction more than 4 centimeters. That is a concept that you have to keep in mind. So that ends the mandible. Now we are going to the last part of this oral cancers. It can take some half an hour for this. We will complete this. So lip cancer is the most common affecting the head and neck cancer, similar to that of skin cancer. So lip and skin are very important. So incidence is almost 13 in North America, and it is higher in the Western countries rather than our country. Why? Because they are skin cancer prone zones. Skin cancer prone. Okay. Following factors are important, like solar radiation. Number 1 is solar radiation. Number 2 is tobacco smoking. Number 3 is viruses. You can keep it in mind. Solar radiation, tobacco smoking, and viruses. So it is exposure of the sun is which is very important. That is why foreigners, when they come here, cricketers, especially England cricketers and all, so they wear that lip protectors. Okay, sun protectors, sun protecting bombs, sun protecting bombs. Sun protecting bombs, especially countries in the equator, that is especially in African countries and all, it is more common. They use sun protecting bombs. That is the anti-tan and that sunscreen lotion they will be using. Men, it is more common. Fortunately, women, they wear more lipstick, but it is common in men only. Almost 95%, 95:5 ratio. Out of 100 lip cancers, 95 occur in males. 95 occur in males, in spite of not using the lipstick and all. So main etiological factor is solar irradiation, means that lower lip is more commonly affected than upper lip. So lower lip, if you take, more commonly affected than upper lip. Okay. So this is 94%. Almost lower lip is more commonly affected. So almost 90% of the tumors occur in the lower lip. So lower lip is very important, not the upper lip. Upper lip is less common, as you could see. In upper lip, what happens is salivary gland tumors are more common. Salivary gland tumors are more common. Salivary gland tumors are. But here, lower lip, the direct squamous cell carcinomas are more common. Squamous cell carcinomas are more common. 7% occurring in the upper lip. 7% occur in the upper lip, and 4% occur in the commissure. So, as you could see, this is 90%, this is 7%, and 4%. Almost like 6. This is 6% if you can take. This is 4%. You can just say that. So 90% are lower lip cancers, 6% are upper lip cancers, and 4% are oral commissure cancers. So what does the lip constitute of? A vermilion border? Okay. So when you take the lip, this is the vermilion border. Vermilion border, and this forms, this is the mucosa, as you could see. Vermilion is the skin and mucosa border, and this is the mucosa, and you have the teeth inside, and this is upper lip and lower lip. So what you have here is the orbicularis oris. Orbicularis oris. Orbicularis oris is the muscle that is present in the lips. Orbicularis oris is the muscle that is present in the lips. Squamous cell carcinoma is the most common histological type. Squamous cell carcinoma is the most common type of histological type, of course, and then followed by basal cell carcinoma. Squamous cell carcinoma is number 1. Next is basal cell carcinoma is number 2. And if you take the non-squamous, I told you upper aerodigestive tract are more commonly squamous cell carcinomas only. The most common is the non-squamous form of the lip carcinoma. It is the minor salivary glands. So there are nearly 1200 minor salivary glands all over the upper aerodigestive tract. I told you 1200 minor salivary glands. Minor salivary glands are present all over the upper aerodigestive tract. When you take that, so non-squamous carcinomas occur in the minor salivary gland, especially in the upper lip. So I told you. So when you take, this is the lower lip and this is the upper lip. So this is 90% chances of here, and then 6% here and 4% here, as you know that. And upper lip more commonly non-squamous tumors, especially the minor salivary gland tumors. Minor salivary gland tumors will be occurring in this upper lip. Minor salivary gland tumors will be occurring in the upper lip. So what are the clinical features? Like exophytic crusted. Exophytic is like a tree-like thing. Exophytic is a tree-like thing, crusted lesions with variable invasion, where they may invade into the underlying muscle and the based on the tumor. So the lip cancer may go into the muscle, that is orbicularis oris, as you know, and then it may go to the maxilla, upper lip, and mandible in the lower lip. Maxilla, upper lip, and mandible in the lower lip. So as you know, lower lip cancers are more common, and then mandibular tumors also more common than maxilla. So lower lip is the most important thing. So it shows the features of actinic sun damage. So as you have seen, sun is the most important factor for lip cancer. Sun damage, it shows crusting, color change, thinning associated with leukoplakia. I told you leukoplakia is a white patch. Leukoplakia is a white patch. I already told you in the previous class. Leukoplakia is a white patch. How do you stage? They are similar to that of oral cavity. Lip cancer are similar to that oral cavity. So T1, you can say, for example, it is 2 centimeters, less than 2 centimeters, less than 2 centimeters. T2, for example, is in between 2 to 4 centimeters. 2 centimeters, you can say this is 4 centimeters, between 2 to 4 centimeters. T3, what happens is it is more than 4 centimeters. 4 centimeters, 2 centimeters, this is more than 4 centimeters. T3 is more than 4 centimeters. And T4, as you could see, T4A and T4B, as you could see, simply as that. As we have already discussed about this, T4A and T4B, you can say T4A is deep soft tissues, adjacent bone and skin. For example, upper lip is going into the maxilla, upper lip is going to the maxilla, it is T4A, lower lip is going to the mandible, it is T4A. Okay. Okay, adjacent bone and soft tissues and skin. Adjacent skin also T4A, you can say like that. Whereas T4B, when you want to take it like this, T4B, what you have got, it is going to the skull base. Pterygoid plates are involved. Pterygoid plates, skull base, and as you could see, it is. If this is the internal carotid artery, it is encasing the internal carotid artery. It is encasing the internal carotid artery. All this comes under T4B. All this come under T4B. What are the investigations you want to do? Early stage investigations are not at all directly seen. They present early to the doctor because they are related to aesthetic sense. Lips are beautiful points. Aesthetic sense, they come to the doctor very fast. So particularly if bone is involved, CT and MRI can be gone for the mandible and etc. It helps in the staging and planning the jawbone, whether you have to remove or not. So you have to go for mandibulectomy or not, or maxillectomy or not. So mandibulectomy and maxillectomy, all these things are seen through this particular. So you have to go for maxillectomy or you have to remove the mandibulectomy. When this is involved, whether you have to do it or not, it is done by means of CT scan or MRI scan. CT scan or MRI scan. These things can help us. How do you treat early stage tumors? That is simply early stage tumors. You can go for surgery or radiation with equal effect. There is also something called as photodynamic therapy along with radiation. Photodynamic therapy. Radiation is done by means of brachytherapy. Brachytherapy. What is brachytherapy? You are putting an implant there, like for example, iridium 192. We'll see later. Iridium 192 is kept inside. That is called as brachytherapy. That is radiotherapy. So survival rates are nearly 80% for T1 and T2 tumors, and dropping for T3 and T4 tumors, it drops to 50%. It becomes bad. So cervical nodes is a poor prognostic indicator. I already told you cervical lymph nodes. Cervical nodes are present means almost the prognosis drops to 50%. Cervical lymph nodes are involved means the prognosis drops to 50%. The prognosis drops to 50%. In 15%, there is local and regional failure. What are the factors that affect the choosing the patient? Like anatomical position is very important, and patient's factor is also very important. Smaller lesions that are there, simple surgical excision. Where lip is having a small lesion like this, you can excise it wedge closure. Okay, less than 1/3, more than 1/3, and full. They'll say. They say full involvement. So less than 1/3, simply you can do wedge excision. You can remove it and then close it primarily without anything. You can go for external beam radiotherapy also, which is acceptable in elderly patients. Elderly patients, you cannot do surgery, you can go for EPRT. Larger lip needs reconstruction. Larger, for example, if you are remove this much of lip, you have to go for reconstruction options like flaps. You have to go for reconstruction options like flaps. So the amount of reconstruction and type of reconstruction, they relate to the extent of lip resection. So once again, telling surgery for cancer is number 1 resection, number 2 is reconstruction, number 3 is rehabilitation. These 3 things are there. So when you have to resect, you have to reconstruct, and then you have to go for rehabilitation. So based on whether adjacent tissue is involved or not, and lip is related to aesthetics. So therefore, you have to keep in mind about this aesthetic component also. And functional outcome, that is rehabilitation, you should see. For lip to function, you should have a sensitivity. That is, there should be sensory supply should be there. Sensory supply should be there, and muscle function. Muscle is functioning or not, you should say into consideration. So physical, medical, and psychological condition, they will help us to see whether primarily you have to go for surgery or radiotherapy. Which one you have to take means it is depending upon the situation of the patient. So what is that you have to go for lip repair? So there are few words here. I'm going to details of this, but you need not remember all these things. Just few words, very important words you can remember. Whichever I highlighted, you just see. Rest all you forget. No need to worry about. The ablation and reconstruction. Ablation is removal, and you have to later on reconstruction. It is done at the same time. The lip should be having a good sensation. The lip should be having a good motion. The lip should prevent the drooling. The lip should permit the speech. Okay, and with this cosmetic appearance, how many things are there for lips? Lips are very important. By this way, you will understand the importance of lips. Okay, so whenever possible, you should go for full thickness skin flaps. Partial thickness or full thickness. Split skin graft is having 1/3 of the dermis, complete epidermis. Okay, full thickness is complete dermis is also involved in that. That is, you should have skin, muscle, and mucosa. This is called as full thickness skin flaps. Full thickness skin flaps. These are called as full thickness skin flaps. You should provide a sufficient mucosa along with commissure to avoid the contractures. So if you do not do proper surgery, it leads to what is called as contractures of the lip. Contractures of the lip. So basic procedure is the lip shave and mucosal advancement. So superficial changes affecting the external vermilion of the lip, such as leukoplakia. For leukoplakia and actinic keratosis, they are managed by lip shave and mucosal advancement. That means you are going to remove a part of lip. So something for the vermilion. This is a vermilion border. I told you, is it or not? Skin and mucosa connection is called as this is a vermilion border. So external vermilion, if it involves number 1 leukoplakia or actinic keratosis, what you have to do? To go for lip shave. Just remove it, this part, and then you take the mucosa of the lateral part and then advance it forward, and then you can do suturing. So that is called as advancement, mucosal advancement. Okay, that is called as mucosal advancement. With extensive, if the malignancy is higher, pre-malignant changes, entire vermilion has to be removed. So vermilion has to be removed. Entire vermilion has to be removed as part of excision. So after adequate excision of the vermilion border, mucosa of the residual labial sulcus is mobilized down to the gingivobuccal sulcus. So completely whatever is there at the vermilion border, you have to remove. If it is a larger lesion, so larger lesion, for extensive lesion, you have to go for adequate excision, and then residual labial sulcus aspect of the lip is mobilized down. So whatever residual labial sulcus that is there, that has to be mobilized down. So blood supply is maintained by lateral margin. Blood supply of this particular tissue is by lateral margins. A horizontal relieving incision in the buccal sulcus is required to allow sufficient mucosal advancement. So when you take the lip, open the lip like this. For example, these are the teeth. So you have to give incision at the gingivo-buccal sulcus and gingivo-labial sulcus. This is the gingivo-buccal sulcus, so buccal cavity. This is the labial sulcus, gingivo-labial sulcus. So that you can go for mucosal advancement. This mucosa that is there over here in the normal side is advanced forward. The undermined mucosa is advanced to the edge of the previous vermilion excision, and accurate alignment restores the vermilion border. So from here, whatever the mucosa is there, you can go to the level of vermilion border. So this advanced mucosa, this is called as mucosal advancement. It is sutured to the remnant lip with absorbable, interrupted resorbable monofilament sutures. Resorbable monofilament sutures like catgut. For example, you can use catgut. Chloramphenicol ointment is always helpful for healing and irritation from the sutures. What is the ointment that you give? Chloramphenicol ointment. Just remember, for any suture problems, you can go for chloramphenicol ointment. So loss of sensation is a side effect for few months. So loss of sensation will be there. We need to maintain the sensation of the lip. You should know the sensation of the lip. If not, you cannot feel the food. You should also go for sunblock. Sunblock or sunscreen lotion. So the techniques used for lower lip. So first we are going to do the lower lip. What we are going to see. So less than 1/3. For example, less than 1/3 they are infiltrating lesions. Smaller lesions you go for a wedge excision. Smaller lesions. What is a wedge excision? If this is a lesion, you go for a wedge excision with 1 centimeter margin. 1 centimeter margin, and then later on you can close it directly with a suture like this. So smaller lesion, wedge excision. In closing the defect, vermilion is temporarily absorbed. So vermilion is approximated with resorbable suture. So this will allow the muzzle to be closed in 2 layers. Muzzle can be closed in 2 layers. So the external skin is closed with monofilament. Labial intraoral wound is with a resorbable suture. So internal wound is resorbable suture. External skin is monofilament, that you have to remove it. Internal skin for resorbable suture. Internal skin by resorbable suture. Just a moment. External skin is closed with interrupted. So externally you have to remove. You have to put removable sutures. Internally you have to put resorbable sutures. There is some technique called as W-plasty or half W-plasty to avoid the bottom of excision to the crease line. So what is the technique useful here is called as W-plasty. So lower lip defect between 1/3. So that was 1/3, less than 1/3. Between 1/3 to 2/3, what should you do? You have a different surgical approach. So what is the names called as Abyss flap or Abyss Estlander flap, or rotation of the tissue via Therapeutic flap. So there are 3 names. Just you can remember the names. That's it. Abyss flap, Abyss Estlander. These are high end, that not required for your level, but just for the sake of understanding. Therapeutic flap. Therapeutic flap. So all these things are there. You can go for reconstruction with these names. That's it. Just remember the names. No one will ask you anything about it. So the Abyss Estlander flap is based on labial artery. What is the artery that is supplying the flap? Every flap should have an artery. It is called as labial artery. So it is a triangular full thickness flap from the upper lip. So from the upper lip you are taking to the lower lip. So triangular full thickness flap from the upper lip you are transferring to the lower lip. So the width of the flap is 2/3 of the horizontal length. So what is the width of the flap? Is 2/3 of the horizontal length, and vertical dimension is same as the surgical lip. For example, this is a lower lip. You have removed this much part. So vertical dimension is same, but width is 2/3. Width is 2/3, and height is same as the upper lip, as you could see. So it is based on labial artery, as I already told you. It is a full thickness incision is given with 2 mm of advancement. For example, upper lip is there. 2 to 3 millimeters of advancement is given from the vermilion border, and then it is transferred to this part. So it is a layered fashion flap. Okay, of course, and it takes 2 to 3 weeks, and the pedicle is divided. So once this upper lip is supplementing this lower lip as a flap, after 2 weeks you can remove the blood supply. So initially it is connected like this. Later on you can cut it here. Here is taken to reconstruct accurately with a white line. So you have to reconstruct accurately. That was Abyss flap. What is Estlander modification? Previously was Abyss flap. Now this is Abyss Estlander modification. So cross lip flap is to reconstruct the oral commissure. So when you take this is the oral commissure, when you are trying to reconstruct the commissure, is Abyss Estlander. OC is Abyss Estlander. Abyss Estlander, that is oral commissure. Abyss Estlander. So when you are taking the oral commissure, it is Estlander flap. The commissure is thus rotated, transferred to the defect in the lower lip. So you need to go on a soft diet. When venous compromise is there, you should be very careful. This is one of the complications that can occur. So you use the medicinal leeches to deal with the venous stasis. Medicinal leeches usage in the case of lower lip cancers, as you could see. Lower lip post reconstruction, you can use medicinal leeches. Post reconstruction, you can use this. The pedicle is divided after 2 to 3 weeks. So Abyss flap is over, Abyss Estlander flap is over. Next, the last one is the Karapansic flap that you want to use. So more than 2/3. If it is more than 2/3 of the defect, you have to go for lower lip in the midline. So lower lip in the midline, it is a Karapansic flap. Karapansic flap. So more than 2/3 Karapansic flap. So the nerve, the blood supply to the orbicularis oris muscle is rotated so that the sensate flap. What is the importance of this Karapansic flap? It has got a lot of sensation and functional lip reconstruction. Lip is a functional lip reconstruction. It is a functionally good flap. It is a functionally very good flap. So that is Karapansic flap. Where is it rotated? Actually, if we take, these are the lips, this is the nose, this is a nasolabial fold. So nasolabial fold is a very important. Nasolabial region rotated medially towards the lip. From here, it is taken to the lower lip. That is called as Karapansic flap. This is the nasolabial skin is helpful. The lateral incisions are there in the, for example, this is the lip and this is the nose. This is the nasolabial crease. The incision will be given at this point. So tumor resection is performed in the usual manner and later on Karapansic flap is done. It is important, don't divide the muscle fibers and neuromuscular control because it is a functional flap. You have to give the neurovascular control. So you have to be mucosal incisions. Where do you place the mucosal? If you take, this is the upper lip, this is the lower lip and upper teeth like this. This is the lower teeth. So mucosal incisions are to be placed over here. So from here the flap is taken over towards the lower lip. It is elevated in a subcutaneous plane, superficial to the orbicularis oris muscle. This is nothing but the Karapansic flap. Karapansic flap. Only just remember the name for lower lip. So medial mobilization and midline closure is done, and for a repair of defect begins with the vertical midline closure of the lower lip. So vertical midline closure is done. So the advanced muscle in the orbicularis it is closed in the midline, and reapproximation done with advanced cutaneous margin of the flap. The residual cutaneous margin of the chin and nasolabial region is undertaken. So once you take, for example, this is the lower lip, so this is the nose. From this region, you take the flap and then advance it and then go towards here, and then later on you close this region. That is called as the Karapansic. Just remember the name Karapansic flap. Karapansic flap. So the side effect of this is microstomia. Sometimes there will be microstomia, but it is good in it is okay in elderly patients with skin laxity. The stage is that gradually later on physiotherapy improves. The microstomia improves with physiotherapy. So you have to go for physiotherapy or muscular exercise around the mouth. So if it is greater than 2/3, for example, lower lip greater than 2/3, what you have to do? Large cheek flaps and transfer. So what are the greater than 2/3? You go for bilateral Gillies fans flap and Bernard Webster cheek rotation flap. So less than 1/3, 1/3 to 2/3, and greater than 2/3. So if the lip is less than 1/3, it is a primary closure. You have to go for wedges resection and primary closure. 1/3 to 2/3, Abyss flap, Abyss Estlander flap, Estlander flap, Karapansic flap. Greater than 2/3 is Gillies fan flap and Bernard Webster flap. So these are the three things that you have to remember. That's it, not more than this. So Bernard Webster cheek flap rotation. So Gillies fan flap and the Bernard Webster cheek flap rotation. So Gillies fan flap is based on once again labial vessels. It is a full thickness one around the commissure. It is done around the commissure. It extends to the upper lip, nasolabial for once again like a carapancic flap only. And it is advanced to the vermilion border, and labial vessels can be advanced unilaterally or bilaterally in closed in layers. It is a modified fan flap. So Bernard Webster modified fan flap, the classical fan flap, and rotates around the angle of the mouth. So it rotates around the angle of the mouth. So Bernard Webster fan flap, it rotates around the angle of the mouth. So vermilion is reconstructed by mucosal advancement and divided after 14 days. So Webster cheek advancement flap, it is one more type wherein horizontal incisions are done laterally from the base of the defect and the commissure. So horizontal incisions are done laterally from the base of the defect and the commissure. At the oral commissure level, we are going to do that is called as Bernard Webster flap. I already told you. So it helps in formation of 4 burrows triangle. What they do is you take a triangular skin incision. So once you have a tissue like this, these triangles are closed and then approximation occurs. So tissue will advance forwards. This is called as Burroughs triangle. So when you are giving an incision, you are taking a triangle called as Burroughs triangle. So once you pull it like this, it gets approximated like this, above and below. Approximated like this, above and below the lateral aspects. Just a moment, a small call. So these are the 4 Burrow triangles that are exercised above and below that you have got in above and below and the lateral aspect of the flaps. Okay, they are advanced bilaterally closed in layers. The vermilion is reconstructed. The vermilion is always reconstructed by mucosal advancement or fan flaps. You can take from the tongue also. Vermilion is advanced. So what about these Burroughs triangles are formed at the edge of the lower lip resection. So when you take the, for example, this much of tumor is there, Burrow triangles are formed here, and so that you can pull the skin this side and this side, and extend laterally from the base of the defect. The mucosa from the base of the excised burrows are rotated inferiorly, and free margin is closed to reconstruct the lateral vermilion of the lip. So these are all the techniques that you are going to do. The flaps are advanced medially and triangles are closed. As I already told you, when the flaps are advanced medially, the triangle closes automatically. The triangle becomes like this. Okay. The flaps are approximated in layers. What is the last technique that you have? The free tissue transfer is good. So it creates a total or remaining lip. Free tissue transfer is the final most, the latest technique of reconstruction is free tissue transfer. Just remember the word free tissue transfer. So they can be in the cheek, skin, and underlying mandible. Anywhere you can do that. So radial artery free forearm flap. This is one of the important free tissue transfer along the palmaris longus. You will be doing this. Of course, the problem with this is palmaris longus is insensible. The sensation is not there, and it is immovable. It is a static one, but mobile upper lip is there. It will help to compensate. So you can go for double paddle flap with palmaris longus and once again palmaris longus. And skin contour is not accurate, not very good as far as the aesthetics is concerned. Aesthetically bad. This palmaris longus. It remains. Sometimes it is as a hanging one. Ptosis is there, and you have to go for wedge excision. So once again, if it is hanging, you have to go for wedge excision so that the hanging will be decreased. Similarly, the final thing that you can go for is facial slings. In facial paralysis, you will be going for facial slings to maintain the lip closure. The function of the lip is to close and then prevent the drooling. That you have to go for facial slings. So that completes the lower lip. When you take the upper lip, so defects can be less than 1/3, 1/3 to 2/3, and more than 2/3. That is complete defects. These are the defects that are found that are there. So all these things are almost having something like up till 1/3. What would you do? Wedge excision is known and advanced flaps, and you can go for almost half of the upper lip you can remove. So aesthetic subunits have to be maintained. Always you have to maintain the beautification. Less than 1/3, it is closed primarily. You need not go for any reconstruction. 1/3 to 2/3. If you take 1/3 and 2/3, So it is perialar crescentic advancement flaps, something which is used. They are called as cross lip flaps from the lower lip. So if lower lip is involved, you take from upper lip. If upper lip is involved, you take from the lower lip. This is how you give the help to the lips. So this guy is the advancement. What is that? Perialar crescentic advancement flaps are there. More than 2/3, what we do? Burrow defect batch reconstruction can be performed. Burrow defect batch reconstruction can be performed. So it is laterally advanced, but laterally based advancement flap, and you can also go for by perialar crescentic excisions, provide the adequate advancement. So these are all the things. So what you have to remember there is FBS and upper lower lip, simply just less than 1/3 wedge resection, primary closure, 1/3 to 2/3. You have to remember FB's flap, FB Estlander flap, and Carapanzi flap. More than 2/3 Bernard Webster flap or Gillies span flap. So these are the names that, supposing if anyone wants to remember, these are important names. And here upper lip, you can say upper lip more than 2/3, this is Burrow defect back, or less than 1/3 you can go for perialar, less than 1/3 you can go for perialar crescentic excision. So these are just names that you can remember of importance. So what about the neck in the cancer, lip cancer? You have to go for so squamous cell carcinoma of the lip does not be as lethal, is not very dangerous as other sides of the oral cavity. Why? Because they present early. Lip cancer present early, less than cervical metastasis, lesser cervical metastasis are there. Very small lesions without palpable cervical metastasis. Cervical metastasis is not very much there. So it is local recurrence rate is low. It is a good thing, and ease of surgical excision. You can easily excise the lip cancer because bones are not very involved until they go for T4. Okay. Even re-excision is also there. Almost for 80% you can go for re-excision. So synchronous at a time forming metastasis increases as the size of the tumor. The synchronous primary increases as the size of the tumor increases. So lymph node metastasis is proportional to size of the primary, as you know that already I have told you. Lymph node metastasis is equal to size of the primary. The primary lymphatic drainage to the lower lip is submental. As you know, lower lip it goes to submental lymph nodes. So submental lymph nodes. Here are the submental lymph nodes. That is 1A lymph nodes, group 1A lymph nodes. And they go to submandibular lymph nodes, 1B. So if you take this is the mandible, okay, this is submental lymph nodes, these are submandibular lymph nodes. This is 1A and this is 1B, as you know that. So neck dissection is not generally performed because cervical lymph nodes are not there. Very less lymph node metastasis. Less than 5% develop the recurrence. So radiotherapy techniques. Small tumors equally, you can surgery is equal to radiotherapy. Small tumors surgery is equal to radiotherapy. T1, T2 tumors surgery equal to radiotherapy. But cosmetic results are bad for radiotherapy. So minor surgery for less than T2 is a minor surgery, therefore you can do it easily. So under local anesthetic itself, you can remove the tumors. What is external beam radiotherapy? I told you external beam radiotherapy is, so there is something like a CT scan unit, the patient will be sitting there and rays will be coming. That is called as external beam radiotherapy. You go for ortho voltage itself. So kilo voltage, ortho voltage, mega voltage. So these are the things. The ortho voltage itself, you give. So 50 gray, 15 fraction, 3 weeks. 50 gray is the unit for radiotherapy. 15 fractions and 3 weeks you will be giving for this particular ortho volt radiotherapy. What is brachytherapy? I already told you EDM 192. 192 EDM you are going to go for brachytherapy in the treatment of lip cancer. So 4 to 5 days you will keep 45 grays and 10 fractions you will be giving. So you will put a iridium pellet inside the lip. This is a lip, you have to put a iridium pellet, and then example is Paris system. Horizontally parallel to the mucosa. What is Paris system? They put needles horizontally parallel to the mucosa. 9 mm spacing will be there in Paris system. Just a name. And last one is photodynamic therapy. Last part of this oral cancer is photodynamic therapy. It is helpful in the cancer treatment of the lip. So photoporphyrin is a dye that is injected intravenously. Followed by 4 days later, they give thermal illumination. What is photodynamic therapy? Photo means they give a light dose of 20 joules per centimeter, 100 milliwatts per square centimeter, as you could see here, 100 milliwatts per square centimeters, and complete response rates comparable to radiotherapy. So photodynamic therapy is similar to radiotherapy. You will have a light dose of 20 joules per centimeter. This treatment works by cold photochemical process. So it kills by means of cold photochemical process because of chemical cells are killed. and leads to apoptosis and vascular shutdown. And there is less scarring. It is very good compared to the radiotherapy or surgery. Surgery and radiotherapy is better than, not better because less scarring by the photodynamic therapy. Photodynamic therapy has got less scarring. This is a word that is photodynamic therapy is there in your book. You can just read it. Experience suggests that light sensitivity and pain following the treatment may limit its general application. What are the disadvantages? What are the disadvantages? Light sensitivity is there, photosensitivity is there, and pain will be there. So one advantage here is that lack of tissue memory for photodynamic therapy can be given a number of occasions. So there is no memory. Memory is not there. Therefore, it is a good thing. It can be repeatedly given because of lack of tissue memory for the phototherapy. So this with this we complete this one. So as you could see, this is very simple. This is very simple that you understood many options about this particular oral cavity tumors. So oral cavity tumors being, as we have seen, so we have got many things like number 1, buccal cancer, number 2, floor of the mouth cancer. You should keep in mind what are the areas that are there. Number 3, tongue cancer. Number 4, alveolus of mandible. Number 5, alveolus of maxilla. Number 6, retromolar trigone. Number 7 is lip cancer. Okay, so these are all the areas we have extensively covered all these things, of which if you can see only subheadings are important. Don't go for details of this. Subheadings are important. Just have a superficial reading in which is given in the textbook. I have gone extensively only because you will understand, not that you have to remember everything. No need to worry. Don't worry about all this. Higher level knowledge I have shared with you because the PowerPoints are available, and then because you will have a basic understanding of what is oncology, and some people might be interested in oncology in the future also. So for that reason, I have gone for this complete extensive reading. And after this, we have to go for oropharynx, to go for hypopharynx, to go for larynx, and we have to go for salivary glands. So these are the 4 things that are there that will be completed in the coming classes. So these are also superficially important for you, deeply not important. And later on, we'll be going for concepts of neck swellings. Once we'll go for it, and then the neck dissection we'll go for it for understanding. Okay, neck dissection will go for understanding, and then based on this only we'll complete the oncology part of your understanding. So most important among this is the larynx, and sometimes you might get oropharynx and hypopharynx. So oropharynx and hypopharynx anatomical aspects are important. So whatever I told you in these classes, I'm been telling you in these classes, is important for at least 2 marks or 4 marks. So larynx cancer can come for 10 marks sometimes. So larynx cancer can come from 10 marks. So coming 4 to 5 classes, almost by now itself main part is over. 4 to 5 classes or oncology sessions will be done, and then we can plan having a revision or something like that based on the discussion in the department. Okay. Thank you very much for the patient listening. Hello.
Yes, sir.
Yes, sir. Thank you, sir.
Are you able to follow anything which I am telling?
Yes, sir.
Yes, sir.
Okay, I think the subheadings are important. Don't go into details of all these things. Okay, you can just anyhow put the class once again recorded version. Only subheadings are important. Don't go to details. Details are not asked in oncology for you people. But you should understand. Only sense I am dealing with so deeply is you should understand what is the anatomy of ENT and what is the basics of anatomy of ENT, so that you will have a fair idea when you are answering the questions. Okay. Thank you very much for the patient listening.